Hello and welcome to our program, Answering the Call, Practical Strategies for Improving Earlier Diagnosis and Patient-Centered Management in Primary Care, Addressing Inequities in COPD Care. Over the past month, we have talked about earlier screening, diagnosis, and risk assessment, non-pharmacologic strategies, pharmacologic strategies, and today, as I said, we're going to discuss the need for addressing inequities in COPD care. I'm Dr. Barbara Yawn. I'm a professor at the University of Minnesota. It's been my privilege to work with the IPCRG for over 20 years and with the COPD Foundation until last year when I retired from there. And I want to welcome my colleague, Dr. Tsiligianni, and I'm going to ask her to introduce herself, please.
Hello, thank you, Barbara, and welcome all to this nice travel today, this nice trip. So my name is Ioanna Tsiligianni. I'm from Greece, which is very warm at the moment, and I am the past president of the International Primary Care Respiratory Group and associate professor of general practice and public health in Crete, Greece.
Thank you. Well, our learning objectives today are to identify socioeconomic, psychological, health system related, and multi-morbidity related factors that can impede access to an accurate diagnosis and optimal care for people with chronic obstructive pulmonary disease, or COPD as we call it. So let's start by talking about COPD in lower income settings. Now, it is different than in high-income settings. In these settings, it is not just about smoking, it's also about smoke. As you know, there are lots and lots of environmental factors, and you can see on the left, there's a paper about impact of asthma and COPD in sub-Saharan Africa. But I really think this map is very, very good at reminding us that air pollution from burning of wood and other biomass fuel kills 2 million women and children each year. And so when we think of COPD, some people may still think, oh, this is an old man's disease. In low and middle income countries, it is a much broader condition. You can see all of the highlighted orange and red. These are areas where really at high risk for concerns because of all the biomass fuel use. So what do we have to contribute to COPD in the lower and middle income countries? We have tobacco use and exposure to household pollution. So tobacco dependency is a big issue. And we need to think about, as the green one says, the tobacco use and smoke exposure is more prevalent. We need resources to support tobacco cessation and to avoid exposure. And these things are less available. And because they're less available but more prevalent, we have an increased risk for COPD. Now, to highlight the smoking, which is a huge problem, this is tobacco smoking, and this is just to highlight that 80% of smokers reside in lower or middle income countries. And it is associated around the world with increased risk in these countries. And the prevalence was highest in those countries, followed by the low income, followed by the middle. And when you see the odds ratios, just to remind you, where it says the middle, the odds ratio is 1.69. That means it is 69% greater risk of smoking in the lowest. And in the middle, the 1.31 means it's 31% higher. And you can look down at this WHO. The Euro, those are Eastern European. The Afro are African American. We also have the Mediterranean countries. All of these countries, when you look at what's called the forest plot on the graphic, you can see there that all of them are higher than one, and only a couple of them, like the European, are across the one. And again, odds ratios telling you we have anywhere from 12% increase to 54% increased risk of tobacco smoking. And this is a huge problem because the resources for tobacco cessation are not really high. This really emphasizes what we have is the background level. That's what the C's are. That's the background level with the tobacco smoke and the other things that are risk factors. But when we add the B, this is biomass fuel exposure from crop waste, animal dung, cooking and heating, and usually not great ventilation. You can see what it does on top. It really increases. Even in the 35-year-olds, we go from a prevalence of COPD with only the tobacco smoke of about 3% up to 5%. And as you get older, you get to the 65, 70-year-olds, it's more than twice the risk when we have the biomass fuel added. So what can we do? What are the unmet needs? And I don't have to tell you these if you work in one of these areas. Healthcare coverage, really problem, because we don't find great structured primary care systems in many of these regions. And when we do have primary care physicians, they are so busy dealing with the urgent and the emergency that it's very difficult to shift and think about longitudinal care and preventive care, like stopping smoking, immunizations, doing ventilation for the biomass fuel. Also, there's fewer diagnostic equipment resources, especially spirometry. And the microspirometry, which is cheaper and more portable, may help this, but those are not always available either. Drugs can be a real problem to be available and affordable, and for people to understand how to use them and not just use part of them and save the rest for the next time. We need to think about access being culturally and linguistically appropriate. One of the things I always fear coming from a high-income country and a very different cultural setting is I have to learn about the culture and the language and what's considered appropriate and comfortable before I can go in and try to set up or help support a system. And the last thing we need, of course, are good medical records. Now, they don't have to be the electronic medical records that we fight with all the time in the higher income countries. They can be paper if they have to. But if you have access to a computer, you may use a computer system kind of like we use the paper without all the fancy gadgets and bells and whistles, but something that you can share medical records with each other. Now, earlier diagnosis, there have been attempts for a very long time to think about how do we point out the people who have COPD, because we miss them a lot. They don't come in, they don't tell us about their symptoms. We only see them when they're having serious problems, and then we deal with just that. This is one of the earlier screening tools developed by David Price, and you can see it talks about age, BMI, smoking, whether or not you cough, how frequently you wheeze, and the allergies. If you have allergies, you're probably less likely to have COPD and more likely to have asthma. And it did add the microspirometry, and it's okay, but as you can see, it really doesn't address things like the environmental exposure, so may not be the most useful for lower income countries. This is the capture. This is a study that I'm working on, and we have been doing it for quite a while. It is being studied in the US. It asks 5 questions, and you can see it does start with, have you ever lived or worked in a place with dirty or polluted air, smoke, secondhand smoke, or dust? And so it does try to address this issue, and it also addresses things like Do you have breathing problems? Whether do you tire more than other people your age? And have you had episodes of cough, work, or things that made you miss work? It adds a peak flow, not a mini spirometer. You could use the microspirometer to get peak flow, but for people in the middle range, it adds for these peak flow measurements. If it's really low, you're probably fine. If it's really high, you really are at high risk. But in the middle, it adds this. There has been some studies. This one is from a Chinese population, and you may remember from that slide from WHO that there is a lot of problem with smoking and other smoking environment in China. So this was a study that compared several of these questionnaires, adding peak flow and microspirometry, and they were able, with the microspirometry, to identify about 65% of the people. And if the microspirometry was abnormal, then they were right about 89 or 90% of the time. But it's not easy to do this on everybody. So people have moved back and added the combination of the questionnaires. And then if the questionnaires suggest it, you use the spirometry. And in this case, they were able to identify about 81% of the people had COPD. And if the test was abnormal, then the people who had abnormal results, about 68% of the time, did have COPD, which means 32% of the time they didn't. The sensitivity sounds terrific and the cost sounds great, but one of the things you need to realize that of this 81%, a lot of these people had milder COPD. Now that may be okay, but they're not in the range ready for therapy yet. And so you may say, well, it is okay to do that because they do need smoking cessation. They do need support for improving the pollution, but they may not need COPD therapy yet. This is one of the tools that was used. This is the Chinese symptom-based questionnaire. And you can see the revised questionnaire is over on the far right-hand side. They ask about age, cigarettes, weight, weather, coughing up phlegm, wheezing, allergies, exposure to secondhand smoke, coughing when you have a cold, shortness of breath, long-term exposure to dust or chemical particles, and problems with respiratory issues when you were a child. Now, this adds some other concepts that are probably important in lower middle income countries, like childhood history. The dust and chemicals, I think that depends on your community. And would they say, for example, that biomass fuel exposure is exposure to dust or chemicals? So you have to know these questionnaires and your community. So in low and middle income countries, COLA-6 has also been used. This one talks about whistling, phlegm, woken up from sleeping, which is actually more common in asthma than COPD, missing work, hospitalized, currently smoke, or do you use biomass fuel daily? This is the only one I'm aware of that actually specifically asks about biomass fuel. It then adds age, and it adds your peak flow. So this one may work very well, particularly in areas with lots of biomass fuel. This is the lung function questionnaire. I just put it in here because it's one that I worked on a long time ago, but I don't think it's really going to be that helpful in countries with lots of biomass fuel. Because it talks about how much you feel short of breath and coughing up stuff, which are important, and the breathing problems, tobacco, but then it doesn't ask about biomass fuel. It just asks about how old you are. So I think that this probably wouldn't be my first choice if you're in a high region of biomass fuel use. This is comparing the characteristics of the ones we talked about, the capture tool, which is in the green, the COLA 6, which is the one I said I thought specifically asked about biomass fuel and added the microspirometry, and I like, and then the lung function questionnaire. Well, you can see that the lines really are very similar in the Nepal group and in the Uganda group, but in the Peru group, the lung function questionnaire kind of falls down. And I think this is because it does not address this issue of biomass fuels. But if you're going to use one, and you have one you really like, trying to think about this and identify people this way may be appropriate with any tool you want to use. One of the things we do have to think about is health literacy. When we talk to people, we obviously think about their literacy in general, and you're not going to give written instructions to someone who has trouble reading or cannot read. But we also want to think about their health literacy. How well do they understand health concepts? And I wanted to show you this because there has been data to say that people with poor health literacy have greater COPD severity, they feel more helpless, they have worse quality of life, more morbidity, more emergency room visits. And so the recommendation is to assess health literacy. But I'm concerned that these are the tools that we have readily available. And I find these difficult to use even in a high literacy area or a high income area because they're written at about 15th grade level. Look at some of these questions. The concepts are really important, but feeling understood and supported by healthcare providers, having sufficient information to manage my health. Number 5, appraisal of health information. Those are complex words and may be difficult. So I hope somebody is redoing these and rewriting them in ways that you can assess in a multitude of countries at a much lower reading and health, not just health literacy, but literacy level all over. We also need to think about, if we're going to use telehealth and other things, about e-health literacy. And those things we need to ask about. Can you use technology? I wouldn't use these exact questions, but I think the concepts are great. So if we think about telehealth, it may really help because of the transportation problems, the distance from specialty and primary care, and the problems of trying to take off work and travel these long distances, and work may be just your usual activities. So using, whether it's video, digital telehealth, or telephone telehealth, I think is a potential real solution to some of these problems. Now, when we talk about the digital and Zoom things, this could be a challenge for some of our older patients who may be less comfortable and have less access. But I think there's also some challenges for us. If we're going to use the telephone, I have to learn how to assess my patients, not with a visual, but just with the telephone. And that takes some real work. If you're going to do the video or other Zoom conferences, this one just reminds you, you need to be prepared. As you know, just like signing on to this, you can't sign on at the last second and assume it's all going to work. You have to review how you're supposed to do it, the patient's history, check your connection. You want to greet the patient and put them at ease. This may not be comfortable for them. You want to ask why they are talking with you today. What are their biggest concerns? What are their goals? You want at the end of the visit to make sure they understood what you talked about. I like to say, we talked about a lot today. Can you give me just 3 things, 3 highlights that you think we talked about that are important to you? And you may find out they and you are on a totally different page. I think it's helpful. So I'm going to stop at this point. And Dr. Tsiligianni, I know you work in this area. What comments do you have to add?
Well, the message here from my side is that I think we must all understand how important it is to have an earlier screening and diagnosis. And I think because I worked also in a rural and remote area for many years, I think we must be very inventory in that. So I will give an example. One of my main problems was that the men didn't usually came to my office because where the woman usually came to my office. So I thought, how can I screen these people for COPD? So what I did, and I give it as an example just to show the importance, is that I decided to write a piece for the church newspaper, which is very well attended by male and female. And I put there the Canada Lung Health Test, and this at the end, for not taking your time, resulted in 40 more newly diagnosed COPD cases. So I think the main message should be about how to screen early and how to find the ways to work with all this system. And obviously the challenges are different from country to country and from place to place, but not so much different, I think, because, for example, in Greece, we never expected that we would have also biomass problems, but there is a lot of wood burning for heating, especially after the economic recession. And we found this a lot in rural areas. And another challenge is the fact that primary care is not very well organized, especially for the longitudinal care. And this is a challenge which may not be in other countries. And we have more pulmonologists than GPs in the country, which is also a challenge.
Yes, but I really like what you said about going where the patients are. If they don't come to you, you go to churches, you go to festivals, you go to whatever it is. We do that in the United States too. We go to the shopping mall sometimes and screen. So I like that.
Yeah, okay. It was just a personal example, just to show how we should probably do it. Thank you. So here I will present about the COPD in women, where I think it's a very important and different topic in COPD, some special, let's say, populations. So you will see why. So the COPD in women is a big chapter because women with COPD usually are underdiagnosed and they have suboptimal treatment. And usually the diagnosis they take, because they develop COPD in an earlier age, they take the diagnosis of asthma more easily than taking the diagnosis of COPD. And the COPD disease presentation is quite different, and women are usually younger, they smoke less, but they have more dyspnea and more exacerbations. The socioeconomic status is different, are likely to be more in a lower socioeconomic level, and the COPD disease presentation is quite different, so we should take this in consideration when treating women. So there is a differential burden of comorbidities, there is more osteoporosis, more anxiety and depression, and there is evidence of greater psychological impairment in women. The tobacco use is a big chapter because of course, in women with COPD, there is evidence that for the same tobacco exposure level, there is greater harm. And there are greater benefits of smoking cessation, but despite that, the challenges are bigger because there is 31% lower odds of successfully quitting in women. And this is something that we should definitely take in consideration. There is a lot of occupational exposure, which is quite different from men because usually they work in unregulated cottage industries such as fish and smoking that's still working, so we should take this in consideration as well. And because they have more domestic responsibilities, they have more chances to be exposed to biomass fuel. So other barriers to assessing COPD care among women are, as we said, the dismissal of symptoms as normal aging, the social stigma associated with COPD, the poverty, which is bigger in women, and the inadequate recognition of COPD in women versus men among clinicians. We still have this problem. The most obvious diagnosis in our doctors is asthma and not COPD. And all this leads to reluctance to seek care. So what is suggested by IPCRG in this desktop helper that you can find in the ipcrg.org is to address reluctance to seek care and develop strategies to address risk factors. So search for biomass fuel, don't expect the patient to speak you about it. Consider COPD as well as asthma and not only asthma. Reassess asthma diagnosis that may actually be really COPD. Based treatment of COPD on GOLD classification, of course, as everywhere. And consider, however, that you need more intensive behavioral approaches and tailor nicotine replacement therapy dose to treat tobacco dependence. I would like to stay for a few seconds here. The nicotine replacement therapy is important to note that we will have to tailor the NERT dose because it is strongly influenced by the menstrual cycle. So we have to schedule the quit date to be close to the follicular phase of the menstrual cycle. And also because cotinine and nicotine metabolism is faster in women, especially if they take oral anticoagulants, we need to use higher doses of NERT when we try to stop smoking by NERT. And all this are information that our primary care physicians should know. And we have to support, of course, pregnant women to smoking cessation and optimize treatment. And for optimizing treatment, we should also consider the comorbidities and especially anxiety and depression. And at this point, I must say that there is a new desktop helper about mental health in COPD in IPCRG, and also use caution in prescribing ICS and consider if ICS withdrawal is appropriate, if appropriate. So smoking cessation, just a summary of what we said. Be aware that women often find it more difficult. Pharmacological and behavioral approach should be used together. Vaccination should be offered as with men, of course, and pharmacological treatments, we should follow the national and international guidelines, but be aware that some medication used to treat comorbidities may also positively affect COPD, and some typical exams may be, for example, statins that we know they have favorite effects also to COPD. They reduce exacerbations, they reduce mortality, they improve quality of life, they even reduce the decline in lung function. Pulmonary rehabilitation, I will not speak a lot because Sally Singh in the previous module said it all. But I think it's important to raise the fact that because women with COPD have more breathlessness and anxiety and depression, they need more support, and they definitely need the pulmonary rehabilitation as symptoms are quite strong. And the oxygen therapy prescribed as appropriate and as per guidelines. So the improving care, I think it's really important to have a tailored patient education. The patient should know that the smoking cessation may be more challenging, and we have to persuade them to have the risk avoidance and the smoking, and also avoidance of passive smoke exposure. I think this is something that we forget most of the time. So, for example, again, in my practice, usually, especially in rural areas, the women don't smoke, and that's good. But the men of the house, they smoke all over the house. So it's the passive smoke exposure is really increased. We have to educate the woman also to not dismiss the symptoms, to speak openly, not feel embarrassed or guilty, and to know that they may be more prone to exacerbations. The physical exercise and the dietary advice is also important, but because they have more risk of osteoporosis, then we should tailor also the dietary advice towards this direction. The symptom burden may be greater, and the inhalation technique and the treatment plan should be as usual. Another special population, I must say, it's the multi-morbid patients. The problem is that we as clinicians, we are used to an index disease. So to think about COPD, to think about asthma, but not a combination of diseases. And this is something that I believe, I'm sure Barbara will agree on that. We should change our mind on that, because if a patient has a chronic disease, a long chronic disease, then the most possible thing is that he or she has multiple chronic diseases, and we should keep that in mind. So the common and clinically important comorbidities in patients with COPD are, of course, cardiac, vascular, gastrointestinal, musculoskeletal, endocrine, renal, other respiratory diseases, and neurological. But it is important to know that multimorbidity in people with COPD increases morbidity and mortality. So we should explore which are these common comorbidities that go with COPD and the ways those function, let's say. So in this scheme, you will see that we have 4 categories. So the first one is diseases that they have common risk factors, like genes, age, or smoking. The second category is the dependent comorbidity, and Alan Kaplan in the first module spoke about that. And for example, he said that when a patient with COPD has also diabetes, the risk of mortality increases by 50 to 70%, which is really important to know and to assess. Of course, there are random comorbidities like acute illnesses and aging-driven coincidental comorbidities. The reason to know all that is because you want to influence this mechanism, and because all these multiple diseases lead to an increased daily adjusted life years, lost years, and also mortality, and we have to find the best way to deal with our patients. And as regards the management of the multimorbid patient, we have to, first of all, we have to identify that the patient in front of us is a multimorbid patient. We have to optimize treatment, to consider the risk for comorbidities when initiating therapy, and carefully consider indication for and risks of ICS use before prescribing. And we will speak more about the ICS and in general about the treatment. But again, all this and also the IPCRG desktop helper on ICS use and withdrawal is available online and in multiple languages in case you want to see it in more details. So the key points is that we have to increase the awareness of COPD multimorbidity. Even in nowadays, I don't think we do it that successfully. I don't think we screen and monitor for the most common comorbidities. And even if we do that, The problem is that we don't take different treatment options when people have common comorbidities in general. We don't treat them in a multi-morbid, let's say, way. And I must say here that all the guidelines are vertical, so they consider their guidelines for this index disease. So for hypertension, we have guidelines. For COPD, we have GOLD and others. But I don't see the guidelines having put all these multi-morbid patient diseases together, which is really crucial. And what we need to do is to have at least a yearly reassessment. It needs to have a treatment adjustment. We have to think about the medication the patients take and stop inappropriate medication. And of course, always, because we have a patient with COPD, evaluate for lung cancer. The review of inhalation technique and adherence, we see it everywhere. The problem is, again, if we do it, if we really do it, if we really test the inhalation technique, and especially if we test it in every visit. So I'm not sure in reality if we really are successful in that. And then we have to empower patients and caregivers to cope with overwhelming information and also depression and anxiety. So as regards the medication in the multi-morbid patient, I think the most important problems, let's say, raised with the inhaled corticosteroid treatment. So the indications are for asthma to continue inhaled corticosteroid treatment, because this is the basis of asthma treatment. For diabetes, if the patient has COPD and also diabetes, we have to reconsider inhaled corticosteroid treatment. And if there is a real need to continue, and the real need to continue is only if we have more than 2 exacerbations and hospitalization and category D, as you remember from the previous module, and eosinophils more than 300 in blood. But if we decide if the patient belongs to this category, then of course we should continue, but we should closely follow up, monitor glucose, and titrate anti-diabetic treatment, because ICS may lead to an earlier onset of diabetes, or make us move from one step of treatment to the next level when ICS are used. Osteoporosis is really important to reconsider ICS because we know from studies, we have big studies, we have the DACORD study, we have also the Locke meta-analysis that shows that ICS influence and increase the risk of osteoporosis. So if there is a need again of ICS, then we should continue, but we should monitor bone mineral density and fracture risk more often, and screen also for osteopenia and osteoporosis. So as a message, ICS should be stopped in these occasions, to my view, and to not only to my view, to the studies that support that. But if there is a strong evidence, if there is a strong way or a reason to consider to continue ICS, then we should be very careful. And for example, the FRAT score should be done in all these patients. And as regards infections, again, we should consider ICS withdrawal. We know that pneumonia risk increases incredibly, fourfold, says the Arctic study, and we should maximize bronchodilation. In case we use LABA, in general, we should closely monitor for cardiac rhythm disorders, and as regards LAMA, we should monitor for emergent urinary symptoms for patients with chronic kidney or prostate disease. So what is needed is an holistic approach to medical intervention and reduction of exposure risk. Usually, as I said, we have a vertical way of thinking. So for COPD, we think pharmacotherapy and pulmonary rehabilitation and vaccination. And for comorbidities, we think guidelines for these specific comorbidities. The reality is that there should be an horizontal collaboration between the two ways, the COPD and the comorbidities, an horizontal line. And we should think the modification of risk factors and how to adapt treatment according to the comorbidities that we have. And this is a summary of what has been presented. So, for example, you see this in the desktop helper, but also in a publication where to suggest LABA, LAMA, and a very nice summary of the ICS and the problems that are related to this. So in this summary, you see that ICS are recommended for asthma and also for the indications that I said before. But also we see that there is an increased risk of pneumonia, osteoporosis, fractures, diabetes and pre-diabetes, which is really important, and I already spoke about that. The bronchiectasis is something that we forget. So ICS are not indicated because with bacterial colonization or recurrent lower respiratory tract infections. And for the tuberculosis, there is also an increased risk with the ICS. And we shouldn't forget the risks of association with glaucoma and cataracts. With LAMA and LABA, the things are easier. So for LABA, the problem is mainly with atrial fibrillation, and especially this is with SABA, with short-acting beta agonist, and not with LABA. And we should take in consideration the risk of tachycardia and rhythm disturbances, while for LAMA, we should take in consideration urinary symptoms and also associated with cataracts, especially the glaucoma, if used with face masks. So LAMA, it's chronic kidney disease and prostate disease that we should take in consideration, and glaucoma. And here is the panel for discussion. So, Barbara, do you really do all that in practice? And do you think we should treat differently our patients with multimorbidity or women? Do you see them completely different? What do you think? What do you think our audience does?
I think that we have to really pay attention to those. And do I do that on every patient every time? Absolutely not. But that's the nice part about primary care and the longitudinal aspect. I may have to deal with an acute problem today, and I try to bring up one of these other issues and then try to get people to come back for follow-up visits, as you highlighted. I think that is really, really crucial to get them to come back and be able to look at it. The multimorbidity, there is just no way we can emphasize that enough. And one of the things that I think happens is sometimes people's heart disease gets diagnosed first, and they forget if somebody has heart disease and is a long-term smoker, you ought to check them for COPD too, because they probably have it.
Yeah, that's true.
Yeah. Well, let's go on. I want to highlight the key points from today. We have access to optimal care for COPD, as we know, is often impeded by socioeconomic, psychological, health system, and multimorbidity factors. We have real challenges in lower income countries because not only are people more likely to smoke and be exposed to firsthand and secondhand tobacco smoke, they also have more exposure to things like biomass fuel. They have less access to a diagnosis and treatment due to distances, economic, logistic constraints, all those things. and the possible strategies to improve care. We might be able to screen to identify these people, because if we don't identify them, we're not going to treat them. So we may be able to do that and then use some of these opportunities for remote care, including care over the telephone if we don't have internet access. We really need to be aware of the risk for COPD in women. And as you very nicely pointed out, we need to think about earlier diagnosis, little bit different symptom. We really have to tailor both the assessment and the intervention, both pharmacologically and psychologically, and the patient education. And we have to recognize the multi-morbidity. And I agree, none of the guidelines really do a good job of putting all these together. They all say, well, follow the guidelines for heart disease and COPD and this and that, and that's very difficult to do. So I think that we probably have time for maybe one question, if anybody has any.
I have answered one question about the learning. Okay, it was about if people with learning problems have more issues with the deal of COPD, and I said that in terms of that we need to spend more time in educating them and make them understand the action plans, how to deal with the exacerbations, and etc. Although there are not a lot of studies on this topic.
Absolutely. You know, I agree. We want to highlight that we need more work on how to deal with people that have different rates of education, learning disabilities, potentially all kinds of things. Great response. Thank you. Well, I think that we are out of time. Thank you very much for joining us today. And please make sure you claim your CME credit by completing the post-test and evaluation at https://integras.com and /COPD eval, which is evaluation, and 54, or I'm sorry, that's S4. Please make sure that you look for this. And if you'd like to learn more about optimizing care for COPD, you can find more programs at integrity.com/COPD 2022. Thank you so much, and thank you, Dr. Tsiligianni, for excellent suggestions.